This is Brian Wood from University of Washington. In this National HIV Curriculum mini-lecture, I will review the IAS-USA guidelines. These guidelines offer recommendations for use of antiretroviral drugs to treat or to prevent HIV. I'm going to focus this talk on the treatment sections, and I plan to summarize the recommendations and also to note places where these recommendations either agree or disagree with other national HIV treatment guidelines. The guidelines were last updated in 2022, and the update was published in JAMA. To start, these are key recommendations for timing of antiretroviral therapy or ART initiation. ART should be started as soon as possible after HIV diagnosis, ideally within 7 days. These guidelines support starting ART the same day as the HIV diagnosis if it is feasible, or starting ART at the first visit for HIV care, if the patient is ready and assuming there is no clinical evidence of an opportunistic infection, such as cryptococcal meningitis. The guidelines recommend starting ART at the time of diagnosis if there are symptoms of acute or primary HIV, and also emphasize the importance of starting ART immediately if HIV is diagnosed during pregnancy. They also comment that for elite controllers, who are individuals with innate immune control of HIV and who maintain an undetectable or very low viral load off of ART, there are theoretical benefits of taking ART, so offering a prescription is reasonable. The guidelines also offer recommendations for ART initiation timing in the setting of an opportunistic infection. They highlight that generally, starting ART within 2 weeks of starting OI treatment is advisable, though they also go into some specific scenarios in which they call out additional considerations. For example, in the setting of tuberculosis without meningitis, these guidelines recommend starting ART within 2 weeks after starting TB treatment, especially if the CD4 count is below 50. In the setting of tuberculosis with meningitis, they recommend starting ART within 2 weeks of starting TB treatment and corticosteroids. And then in the setting of cryptococcal meningitis, these guidelines recommend initiating ART 2 to 4 weeks after starting antifungal treatment. This is one place where there's some discrepancy between these guidelines and the CDC opportunistic infection guidelines, which call out that experts usually defer ART initiation for 4 to 6 weeks after starting treatment for cryptococcal meningitis. This is due to data that early initiation of ART in the setting of cryptococcal meningitis may lead to worse outcomes because of immune reconstitution inflammatory syndrome. I would say that most experts are in agreement that starting ART within 2 weeks of starting cryptococcal meningitis treatment is generally not recommended and not advisable. But then whether one waits between 2 and 4 weeks or 4 to 6 weeks is often a decision that is individualized and made case by case. These guidelines call out that if a person has cryptococcal antigenemia, meaning detectable cryptococcal antigen levels in the blood without evidence of cryptococcal meningitis, based on an analysis of the CSF, then ART can be started immediately. They also highlight that if a person has a new diagnosis of cancer and is not taking ART yet, ART should be offered and started immediately because there are data for benefits, and there should be attention paid to drug-drug interactions, of course. That would be drug-drug interactions between the ART and the cancer therapy. The IAS-USA panel gives this list of recommended initial regimens for most people with HIV. They list them in alphabetical order. You can note that all have an integrase inhibitor as the anchor drug, either bictegravir or dolutegravir, which are two integrase inhibitors that have relatively high barrier to resistance. And then all of the options are combined with either 1 or 2 NRTIs. You can see the first option is the combination tablet bictegravir-TAF-FTC. The next option is dolutegravir with 2 NRTIs, a 2 NRTI combo that is tenofovir based. So this would include either TAF or TDF, that is represented here by TXF, which would be combined with either FTC or 3TC, represented here as XTC. The third option is dolutegravir 3TC, the 2-drug combination, which is a reasonable option for first-line therapy, meaning for someone who is treatment naive and starting their first regimen, though these guidelines have caveats, as you can see listed here. These caveats are very similar to those that are included in the HHS treatment guidelines under their recommendation for dolutegravir 3TC. Now, one major difference between this list and the list of recommended initial regimens in the HHS treatment guidelines is this list does not include the dolutegravir abacavir 3TC option. And I have to say, I tend to agree with this list. I tend to avoid abacavir, not only because of the need to check HLA B5701, but also because in general, I think it is not as well tolerated, and because there are convincing evidence that it raises ischemic cardiovascular disease risk, at least for some individuals. These guidelines also highlight that although integrase inhibitors and TAF have been implicated in weight gain for some individuals, and preliminary data raise concern about metabolic adverse events with integrase inhibitors, such concerns do not override the potential benefit and should not affect our choice of initial therapy. I will come back to this issue later in the talk and call out some other recommendations from these guidelines about the concern for weight gain with specific antiretroviral drugs or classes, which is certainly a hot topic right now. Now, this most recent update of the IAS-USA guidelines did add this language about recommended initial ART following PrEP exposure, meaning after someone has a period of taking either oral PrEP, TAF FTC, or TDF FTC, or TDF 3TC, or after receiving long-acting injectable cabotegravir as PrEP. These recommendations are consistent with the HHS HIV treatment guidelines recommendations. And you can see here that these guidelines call out that if a person acquires HIV while receiving oral PrEP, then a clinician should draw blood for genotype resistance testing, but it is okay to start one of the dolutegravir or bictegravir anchored initial antiretroviral therapy regimens while awaiting the result of the genotype resistance testing. That's because even if a person has acquired HIV with resistance to the tenofovir or the FTC or 3TC, a regimen with dolutegravir or bictegravir is likely to remain active and effective. So those are still the recommended first-line options, even if a person has a prior history of taking oral PrEP. On the contrary, if a person acquires HIV after past exposure to injectable cabotegravir, an integrase inhibitor, they are at risk of having integrase resistance that could affect the efficacy of dolutegravir or bictegravir. So there are added considerations. In this scenario, a clinician should draw blood for genotype resistance testing and should be sure that baseline resistance testing includes an analysis for integrase resistance. And then if starting antiretroviral therapy before that genotype result is available, should start with a boosted protease inhibitor, such as boosted darunavir, with a 2 NRTI combo that includes one of the tenofovir products. And then, once the genotype resistance analysis result is available, if there is no integrase resistance, and if one of the first-line integrase inhibitor-based options is likely to be effective, the clinician could change to that option. Again, this is largely in line with the HHS adult HIV treatment guidelines, and I agree with these recommendations. The latest update to these guidelines also included new advice regarding ART during pregnancy. These guidelines recommend dolutegravir with TAF FTC as a first-line or recommended regimen to consider during pregnancy, and this is in agreement with the HHS perinatal treatment guidelines. The IAS-USA panel calls out that dolutegravir plus TDF XTC, which again indicates either FTC or 3TC, would be a suitable alternative regimen. And if dolutegravir is not an option, it can be replaced with one of the anchor drugs as noted here. These guidelines also call out that if a person becomes pregnant and they are taking bictegravir or doravirine in a 3-drug or 2-drug combination, and they are tolerating the regimen, doing well, and have a suppressed viral load, then it is okay to continue that therapy despite limited evidence for safety and efficacy during pregnancy. But clinicians should counsel about uncertainties and monitor the HIV RNA or viral load more frequently. These guidelines recommend avoiding cobicistat-containing regimens during pregnancy, and I agree with that. The reason is evidence of lower levels of cobicistat-boosted agents late in pregnancy and elevated risk of viral rebound and virologic failure. These guidelines note clinical considerations around other specific regimens, and I will review some of these as well. For example, for the combination tablet darunavir cobicistat TAF FTC, this may be a good option if someone diagnosed with HIV has a history of cabotegravir PrEP exposure and thus concern for integrase resistance, but there is no access to an integrase genotype. In addition, boosted darunavir with 2 NRTIs such as TAF FTC or TDF FTC is an option with a very high barrier to resistance as compared to other combinations, and so may be beneficial in the setting of known or suspected multidrug resistance or integrase resistance, or if there's a high likelihood that someone will miss doses of oral antiretroviral therapy. The doravirine combination options may be useful for individuals who do not tolerate integrase inhibitors. The rilpivirine combination tablets offer a small pill size relative to other combination ART pills, but should only be used if the current HIV RNA or viral load is below 100,000 copies and the current CD4 count is above 200. This is due to data for lower efficacy with high viral loads and low CD4 counts. In addition, the interaction between rilpivirine and PPIs and the meal requirement needs to be considered. Raltegravir is an integrase inhibitor with relatively few drug-drug interactions. It is generally well tolerated. There may be situations in which it offers benefit, though I would say in my clinical experience, even in these settings listed here, I'm often reaching for dolutegravir or other therapy as opposed to raltegravir these days. These guidelines also offer clinical considerations and recommendations when switching ART, and I will highlight a couple of the key recommendations. One, these guidelines emphasize that bictegravir TAF FTC or dolutegravir with 2 NRTIs that includes TAF or TDF tend to remain effective even in the setting of common NRTI resistance mutations such as M184V with or without K65R, especially if the person has already achieved viral suppression. In addition, switching to long-acting injectable cabotegravir rilpivirine requires a lot of clinical and logistical and administrative legwork and strategizing and consideration. These guidelines, like the HHS treatment guidelines, call out that the long-acting injectable is not recommended in the setting of a detectable viral load outside of a research setting. It should be administered by clinic staff, so requires more resources and visits than oral ART. With on-time injections, there is still a small risk of treatment failure and resistance. That risk is likely 1 to 2% or less. And they do highlight that clinicians can collect a proviral genotype before switching if they don't have pre-ART genotype results. This is something I consider in my clinic, checking an archive or proviral or DNA, or also called PBMC genotype before switching to long-acting injectable cabotegravir to ensure there are no rilpivirine or cabotegravir resistance mutations. I don't do this in every case, but do this if a person has taken multiple past regimens and I do not have complete regimen or resistance history, and I'm concerned that there could be archived resistance that could affect either of those drugs. In the setting of virologic failure, there are also a lot of clinical considerations. These guidelines highlight a few suggestions depending on the clinical scenario. For example, if there is at least one active NRTI, dolutegravir plus TXF, XTC, or bictegravir TAF FTC are generally good options and generally remain effective. If there are no active NRTIs, one could consider boosted darunavir plus TXF, XTC, or boosted darunavir plus dolutegravir plus or minus additional agents such as doravirine if it is active or others. Dolutegravir with TXF, XTC, as mentioned, may still be efficacious and may still be reasonable to consider, but there also might be a slightly higher risk of emergent resistance as compared to the boosted darunavir-based options. If a person has low-level integrase resistance, dolutegravir should be dosed twice daily, and if used, should be combined with one or preferably two active drugs from classes that the person has never previously taken. So this could include fostemsavir, lenacapavir, maraviroc if the person's HIV is confirmed to be R5 tropic, ibalizumab, or enfuvirtide. There is debate about whether recycling NRTIs or including NRTIs for which there is not predicted activity is recommended in this setting, and for me, again, that's a case-by-case decision based on the number of active drugs available, and creating a salvage regimen in this scenario really requires considering how many active agents one can use and how much potential benefit the recycled NRTIs may offer. If a person has high-level integrase resistance and PI resistance, then I'm generally reaching for one of those salvage agents from a class the person has never previously taken, plus or minus recycled NRTIs. This is a summary of the laboratory monitoring recommended in the IAS-USA guidelines. I won't go through all of this, but will highlight that at HIV diagnosis or entry into care or before starting ART, these guidelines agree with the HHS guidelines that we need a baseline viral load, CD4 count, and RT genotype, and an integrase genotype only if the person's partner is known to be failing an ART regimen that includes an integrase inhibitor, or they previously received cabotegravir for PrEP. These guidelines, like the CDC OI guidelines, recommend checking a cryptococcal antigen test if a person has a CD4 count below 100. You can see here the recommendation for monitoring during antiretroviral therapy and at virologic failure, with the biggest clinical reminder I will give being that if a person develops virologic failure on an integrase inhibitor, make sure the genotype resistance test you are sending includes an analysis for integrase resistance. Depending on where you work, this may or may not require a separate lab order. Now, turning back to the concern for weight gain and metabolic complications with specific antiretroviral agents or classes, again, this is a hot topic. It is the focus of a lot of discussion and a lot of research these days. And I like the way these guidelines call out some key clinical points that are known, and I want to emphasize that more research and more understanding of this is really needed. But these guidelines highlight that weight gain generally occurs within the first year following start of any antiretroviral therapy. Greater weight gain has been associated with use of an integrase inhibitor or TAF when comparing to use of other classes or agents such as efavirenz, protease inhibitors, or TDF. A degree of weight gain can occur, though it does not always, with a switch from other therapy to an integrase inhibitor with or without TAF. Excess weight gain is more likely to occur for individuals born female and individuals who are Black or Hispanic, and this is reflective of trends in weight gain in people without HIV as well, and is likely related to social determinants of health, and systemic and structural issues. Now, the comparison of weight change between different classes and agents is complicated because the older agents and the agents a person switches from may suppress weight. For example, there are convincing data now that efavirenz and TDF are associated with weight suppression. So the biggest change in weight tends to occur with a switch off of one of these agents to newer therapy. Whether integrase inhibitors and whether TAF directly stimulate weight gain in any way has not been confirmed or fully proven. So the pre-switch regimen certainly has to be considered and absolutely contributes to the likelihood of weight gain after switching to a newer regimen. Integrase inhibitors may be associated with incident cardiovascular disease, diabetes, hyperglycemia, hypertension, or metabolic associated steatotic liver disease. But more data on this is needed. Large cohort studies have had conflicting results, and I do not think that this is fully understood, and we need a better understanding to help predict who may gain excess weight with a specific regimen and the long-term consequences, and also what to do if a person does gain excess weight on a specific regimen. There are not yet clear data for the benefits of undergoing another switch of therapy, and there's a lot to consider in that situation. And these are some of the considerations emphasized by these guidelines. One is that we should counsel about possible weight gain and cardiometabolic complications when initiating or switching ART for all individuals. We should document weight and BMI at baseline and every 6 months. Perform a yearly diabetes screen and cardiovascular disease risk score if a person is receiving an integrase inhibitor. I'll just say I disagree with that one slightly. I tend to do this in my clinic regardless of the type of regimen a person is receiving, and I think that's worth doing whether or not a person is receiving an integrase inhibitor. The guidelines state we should recommend lifestyle changes if a person gains greater than 5% body weight change. I would say that in my clinic, I start talking about these things like healthy eating and exercise even prior to that and even at the time of starting or switching ART. And until there are data proving benefit, switching ART because of weight gain is not recommended. This is also in line with the HHS treatment guidelines. They call this out. I would say that for me in clinic, I do not routinely recommend a switch of ART because of weight gain. However, I have seen a handful of cases where a person clearly gained weight after an ART switch. They have made significant efforts at lifestyle changes, and they are distressed by the weight gain, or they have developed cardiometabolic complications. And in those settings, if there are other active, efficacious options, I do consider a switch, but I agree with these guidelines that I do not do that routinely. I do not routinely recommend a switch of ART or an alternate choice of ART because of weight gain. We may know more in the future which may affect these recommendations. So in summary, the IAS-USA guidelines update provides some very useful clinical advice regarding managing HIV. They emphasize it is generally preferred to start ART as soon as possible. Most people with HIV should start bictegravir or dolutegravir-based ART as their first regimen. In the setting of ART experience and prior resistance development, if at least one NRTI remains active, bictegravir or dolutegravir-based options generally remain effective, especially if the viral load is suppressed. With multi-class drug resistance and no NRTI options, one needs salvage antiretroviral therapy and reaching for agents in classes a person has never taken before, and potentially recycling NRTIs to create an effective salvage regimen. The integrase inhibitors, especially dolutegravir and bictegravir, may lead to greater weight gain than other classes, especially if combined with TAF, but the mechanisms, predictors, and optimal management require further study, and we will learn more about this in the future.
The production of this National HIV Curriculum Mini-Lecture was supported by Grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA Program and do not necessarily represent the official views of HRSA or HHS.